Most welcome.
Good afternoon. I also want to welcome my colleague as well from Medtronic LABS. We are co-hosting under the leadership of the government this learning journey at Kasarani Centre. We are very grateful that we have the blessing of the government to be here and to be able to learn from our community as well as facility leadership as well. Maybe before we start, there were some questions around the facility. How many people do you see? The population that is served?
Kasarani Ward has a catchment population of 65,000 people. And on average, in a day, we see 200 to 250 clients spread out amongst various departments. That is the outpatient, the other clinic, and other clinics, including the rehabilitative clinic and the special clinics. For the NCD clinic, the patients in our permanent register that have been booked to our follow-up, the diabetes and hypertension clients, are 413 from the statistics of last month. Though we keep, in a month, we don't see all of them. The active ones may range from anything between 100 to 200.
So Medtronic LABS, we've been working with this facility and indeed the county. The county for the past, I think it's about 3 years now. So what we do is we want to provide that visibility through the digital technology. One, for us to have visibility on who requires care the most in terms of their risk profile. Second to that is for the general population who are not aware about their condition, how do we make sure that we identify those people who are at risk and we're able to onboard them into care? Thirdly, what we do then again is for those who have been identified and onboarded into care, how do we make sure that we leverage on technology to keep them in care? We know for sure that one of the key challenges with non-communicable diseases is adherence to care because many patients fall off. But are we able to see those patients who've fallen off care? And that's where the CHPs actually come in, because through digital tools, we are able to see patients who are in care, patients who are missed in terms of follow-up, and patients who are completely lost to care.
We are a supporting actor. The main actor is government, and our role is to support the government to be effective in ensuring that all systems in primary and community health are working, and we support the government to ensure that they, one, have the policies and strategies in place, that they, two, commit their own money on budget so that they can be able to make sure that community health promoters are paid, they have the supplies, they have the training, they have the supervision, they have all the equipment that they require to be able to extend that healthcare into the household level. Why is money so important? Money is an enabler to the system. The same way the digital platforms are enablers to the system.
I know the challenges of working within the Kenyan government system, and that it requires a lot of personal commitment to succeed and deliver in the way that you clearly are. So massive appreciation for that. My question is about the use of the data in terms of going up to the county system and up to national level, how that then is used within the policy making and budget allocation system.
Now, the use of data for decision making, yes, all of it is pulled up to the national level. But now at the sub-county level, Susan is able to see the performance of Kasarani sub-county. At the county level, as Dr. Kibe, I can be able to see all the 17 sub-counties.
Does the doctor's notes, are they completely visible to the patient? If they have 100% access to the clinical notes of the doctor?
Yes, we do avail this because sometimes, like you have seen, the client will move from one place to another place. So whenever, if there is need for them to move, then they move records. So that makes it seamlessly easier.
The question I have is around supplies and how you integrate from CHW to the facility. Is there like a supply chain?
Now, the supply chain, health products and technologies, we have three models. which we use. For the CHPs, they get the commodities all the way from the national government. For their program items, HIV, TB, malaria, those ones also come from the national government, including immunization and family planning commodities. When it comes to program line items, the facilities can directly work on their own because they have resources. There's money that they are allocated from the government, so they can purchase based on their needs.